So, very good evening to all the participants who have joined for this meeting. So, this is the first meeting after the constitution of the new council for Spice Road Kerala, and we are happy to have Dr. Aishwarya Thambi. She is a pulmonologist at their hospital, Thrissur, and she did her MBBS from TD Medical College, Alleppey, and she was a good friend of mine. And she completed her post graduation from Thrissur, and currently she is working as consultant pulmonologist at their hospital. And is an excellent speaker. And I hope this will be a very important topic coming to the practice perspective as well as the exam perspective. So that is why I have chosen this topic for starting of the academic sessions for the new council for the year 24-25. So over to Dr. Aishwarya for the deliberation.
Thank you so much, Dr. Vishnu. I'm very honored to be here. And I was very much thrilled when Dr. Vishnu has invited me as a faculty for AFPI this session. And he was my senior in my UG times. So thank you so much for this opportunity. So today I have selected the topic NTEP guideline for TB management for presentation because I think this is very relevant for today's time as we recently only celebrated the World TB Day on March 24th. And currently, this year, the theme for World TB Day was, yes, we can end TB. And every clinician in one way or another, they will come across a TB patient, either for diagnosing or for treatment of TB or for management of adverse drug reactions and all. So it's very important that every primary health physician must have a basic awareness and knowledge about the TB, how is it diagnosed, how is it managed, and current guidelines and all. So that's why today's session. So I think we can begin the session. I'll share my screen now. Is it visible? One minute. I'm not able to share the screen. Dr. Vishnu, can you share it?
Yeah, you can send it to me. I'll
just send it in the WhatsApp.
Or I'll make you the host and you can just try once.
Okay, I'll.
Can you just try once? I've made you the host.
Okay. It's not possible, I think. I'll share the link 1 second.
Actually, can you just change the host to me?
Sorry?
Can you just change the host
Okay.
I have made you the host.
Okay,
Yes.
okay. I have changed it. Topic.
Is it visible now?
Yeah, it's visible.
I think you can start.
Okay. So, good evening, all. Today's topic is on National Tuberculosis Elimination Program. So, this is a program conducted in India under Ministry of Health and Family Welfare for current treatment of TB and management of adverse drug reaction of tuberculosis. So, can you change the slide? Yeah. So, WHO's Sustainable Developmental Goal have a vision of a world free of TB with a zero TB death, zero TB disease, and zero TB suffering. And they have a goal to end the global TB epidemic, that is less than 10 cases per 1 lakh population by the end of 2030. And they have set some target also, like reducing the number of TB death when compared to the 2015 to around 90%, and reducing the TB incidence rate as compared with 2015 to around 80%, and zero families facing catastrophic expenditure due to TB. So India has committed to end the TB by 2025, which is actually a 5-year ahead of the global SDG target. So we have very much near to the deadline, but when coming to the elimination, we are far behind the term elimination. And the Prime Minister of India has launched a TB-free India campaign recently in the 13th of March 2018. And this campaign called for a social movement which focused on the patient-centric and holistic care driven by the integrated actions for TB-free India. So coming to the numbers, there is an estimated global total of around 10.6 million people fell ill with TB in 2022. That is equivalent to around 133 incident cases per 1 lakh population. So coming to India, in 2023 itself, there is around 3.31 lakh people died due to TB and a total number of 2.52 million cases. So coming to the evolution of TB control India, there is a breakthrough in the evolution in 1993 with the beginning of RNTCP pilot program. And this program spread throughout the country and covered in entire country in 2006. And RNTCP, as you know, the full form is Revised National TB Control Program. So under the RDCP came the DOT strategy. DOTS means directly observed treatment short course. So it's also launched in the year of 1993. So this aimed at having a commitment of government towards the TB cure, providing good quality diagnosis and treatment for TB, and DOTS. So what is this DOTS? The TB patient take the TB medicine under the direct supervision of a healthcare worker or a trained person, so that we can assure the 100% compliance of TB medicine intake. And the next. So recently in 2020, the nomenclature for this RNDCP have changed to National TB Elimination Program or NTEP, because previously we were aiming at controlling TB. Now we are aimed towards the eliminating TB. That's why there's a change in the nomenclature recently. So this NTP program has got certain objectives. That is to achieve around 90% of notification rate. We know TB is a notifiable disease. So around 90% of notification rate is needed, and to achieve around 90% of success rate in all treating new patient and 85% in retreatment cases. Also, they aim to improve the outcome of treatment of drug-resistant TB also, and to decrease the morbidity and mortality associated with HIV TB also. recently there is a movement known as System for Elimination of TB in Private Sectors, known as STEPS. So in every states and in every district, there's some private institution. They are given the chance for treating TB and monitoring the TB patients. So STEPS provide an important place in controlling TB, especially in case of a private sectors. So NTEP aim at controlling the TB by 4 pillars. First is detecting all TB patients. So if any patient come with more than 2 weeks of cough, fever, we'll do a sputum smear examination as a screening test for every patient coming to a tertiary care center. And thereby we can find all TB patients reaching to us. And we can treat all the cases with high quality TB medicines. Then by preventing the emergence of TB, and hence by we can stop the catastrophic expenditure by TB. And lastly, we can build and strengthen the supportive systems. So these are the 4 pillars coming under the National Tuberculosis Elimination Program. Now, coming to the topic proper. So who is called as a presumptive TB patient? Any patient with a cough more than 2-week duration, fever more than 2 weeks, with a significant weight loss, hemoptysis. Hemoptysis means coughing up of sputum, blood in sputum, and any abnormality in chest X-ray. So these are the presumptive TB patients. And anyone who have a contact with a microbiologically confirmed TB patient, patients living with HIV, diabetic patients, malnourished one, cancer patients, or those who are taking immunosuppressive medicines, steroids and all, they need to be thoroughly, regularly screened for the signs and symptoms of TB. Now come to the presumptive pediatric TB. Or any children with a fever more than 2-week duration, cough more than 2 weeks, with loss of weight or either no weight gain in children, either no weight gain is also a sign for ruling out TB. Then history of contact with the infectious TB case. So these are the symptoms in case of a pediatric TB. Then presumptive drug-resistant TB. So when will we suspect a patient to have a drug-resistant TB? If any patient who is found to have positive smear on a follow-up treatment on first-line therapy, or if any patient who is previously treated for TB, TB with HIV infection, TB patient who failed on treatment with first-line therapy, or pediatric TB non-responding cases, or any patients with the exposure to a drug-resistant TB case. So these are the patients we need to suspect a drug-resistant TB. So as we know, the signs of TB we have discussed. Any patient with cough more than 3 weeks, coughing up of blood, fever, especially the evening rise of temperature with night sweats, and they may have excessive tiredness, fatigue, unintentional weight loss, and sometimes patient, in case of a pleural effusion and all, patient may present with chest pain, etc., breathing difficulty and all. So any untreated TB patient can transmit the disease to around 10 to 15% in a year. And contact with an active patient itself, we have a 10 to 60 times increased risk of developing a TB. So coming to the case definitions, so TB patients can be broadly divided into 2 categories. One is microbiologically confirmed TB patient. Next is a clinically diagnosed. So who is called as a microbiologically confirmed TB patient? Any patient whose smear examination is positive, or culture for TB, Mycobacterium tuberculosis, is positive, or those who were positive with rapid molecular diagnostic test. So rapid molecular diagnostic test, we know recently CBNAT, TrueNAT, these are all NAT tests. So any patient with either of positive the specimen, we call them as microbiologically confirmed TB patient. Then who is called as a clinically diagnosed one? Any presumptive TB patient who is not microbiologically confirmed, but we diagnosed as an active TB patient on the basis of X-ray findings or histopathological biopsy findings or clinical signs, and we decide them to treat the patient with a full course of ATT. That kind of patient, we call them as clinically diagnosed. So there is a broad 2 category of TB patient. So what are the common diagnostic tools for TB diagnosis? First, we know sputum smear examination. For AFB include Seal-Neeson staining and fluorescent staining. Then come the culture method. Both solid and liquid culture methods are available. Then recently, rapid molecular diagnostic test like CBNAT, TrueNAT, UltraNAT is commonly used for diagnosing TB. Also, the drug-resistant TB we'll look up with line probe assay also. So next, so this is a picture showing how we'll do the seal-Nielsen staining. We have heard much about this in the microbiology classes. So we can diagnose acid-fast organism by doing the seal-Nielsen method. In the next slide, we can see this acid-fast bacilli organism. So the smear examination is actually very simple, rapid, economical method. So smear is used for diagnosing TB, monitoring TB, and defining the cure also. But one thing is that we need at least 10,000 bacilli per ml of sputum to detect it with the sputum smear examination. So smear is very sensitive test, but less, very specific test, but less sensitive. Only 65% sensitivity is there with sputum smear examination. So next, this is a LED microscopic view of an acid-fast bacilli stained with auramine rhodamine stain. So this is less commonly used in our settings. So next, so this is a comparative grading of smear. We'll see the result like sputum smear AFP 1+, 2+, 3+. So this is all made depending on the number of AFB seen per field of smear examined. If we see no AFB by looking up to 100 field, we'll label it as negative. If we see up to 1 to 9 AFB by looking up to 100 field, we'll say doubtful positive. We need to repeat that smear once again. If we see 10 to 99 AFB per 100 field of examination, we call them as 1+. If we see 1 to 10 AFB per field of examination, we call them as 2+. If more than 10 AFB per field, we call them 3+. Likewise, we grade them. Higher the grading, higher the infectivity, and higher the rate of spreading into the other persons. So next come the chest radiograph. We know chest X-ray POV is the initial diagnostic tool. It is very inexpensive, easily available, but it is not specific. Chest X-ray is not specific, but highly sensitive to detect a TB. So it can be used as a supplement for the microbiological test. So this is an X-ray showing upper lobe pneumonia. So this is called as a gone focus. Most common site for affecting TB is the upper lobe. But there is no hard and fast rule that TB can occur only in the upper lobe. TB can present like anything. Like in the next slide, we can see. So in the first X-ray, we can see tiny millet seed-like appearance in the bilateral lung field. So this is a classical appearance of a miliary TB. Usually disseminated miliary TB is seen in immunocompromised like HIV patients. Then next X-ray, we can see left lower lobe pneumonia with a cavity inside. We can see a hypolucency. So this is a lower lung field TB. So this kind of TB is usually seen in an immunocompromised, like diabetic patients, those who want steroid. They usually present with lower lung field TB. So TB can present radiographically like anything. Now, the drug sensitivity testing for detecting the resistance in TB is done either using culture method or by doing the rapid molecular diagnostic test. So liquid culture is otherwise called as MGIT culture, or Lowenstein-Jensen medium is a commonly used culture medium for TB detection. Then rapid molecular diagnostic test, as I've already mentioned, the NAT or CBNAT or TrueNAT is commonly used for detecting the drug resistance, and LPA or line probe assay is also used for detecting the second line injectable drug resistance. So this is a picture showing how the TB bacteria seen in the culture. The yellow colored one, the rough buff colonies suggestive of the Mycobacterium tuberculosis. This is done in the LJ medium. So this is a NAT machine, CBNAT machine. First one showing the CBNAT cartridge, and next the machine. So this NAT is done using a polymerase chain reaction, rapid molecular diagnostic test. So in CBNAT, the result came in the left lower side, right lower side, we see a test result like in a red column, we see MTB detected low. That's how the result come. If the TB is present, the result come like MTB detected, low, high, or very high. And we can also get one other information, if rifampicin resistant is present or not. Here it's written like rifampicin resistant not detected. That means the patient is having drug sensitive TB. So so the CBNAT is otherwise called as expert MTB RIF assay. It's in early 2011, the WHO has endorsed this novel diagnostic test. So by doing the CBNAT, we can detect TB and also we can diagnose whether they are resistant to rifampicin or not. And the result is also get within the 2 hours. So it's very quick and has got higher sensitivity when compared to the smear examination. When smear, we can get only 65% sensitivity, whereas in case of a CBNAT, there is 98% sensitivity of detection of TB bacteria. So this is a diagnostic algorithm of how we'll approach a pulmonary TB patient. So if any patient, any presumptive TB patient will come to us, we'll do 2 tests first. First is a smear examination and chest X-ray. If both smear and X-ray suggestive of TB, we'll confirm them as a microbiologically confirmed TB. If X-ray is not suggestive, but smear is positive, they are also called as microbiologically confirmed TB. The dilemma comes when the X-ray is suggestive, but the smear comes as negative. Then how will we proceed? Then we need to go with the CBNAT examination. In CBNAT, we'll get either MTB detected or MTB not detected. If the result come like MTB detected, we need to look whether rifampicin is sensitive or rifampicin is resistant. If rifampicin is sensitive, we'll call them as drug-sensitive TB and treat them accordingly. If rifampicin is resistant, we need to refer them for an expert for managing of drug-resistant TB. Sometimes the result come like rifampicin indeterminate. That means we need to repeat the CBNAT on the second sample. And in the second sample also, if the result come like indeterminate, we need to go with the line probe assay. So in some patients, if we see like smear is negative, X-ray is not suggestive of TB, CBNAT is also negative. But the clinician thinks that this is TB. He can go with additional tests like bronchoscopic lavage of alveolar lavage to do with sputum smear and CBNAT test, because bronchial lavage has got around 70% additional yield when compared to the smear examination. If everything is negative, but the treating physician thinks that this is TB, he can start him on ATT based on clinical diagnosed TB. So this is how the diagnostic algorithm of pulmonary TB goes. Next, this is how algorithm of extrapulmonary TB. So if a extrapulmonary TB patient come to us, like for example, pleural effusion or lymph node TB, we need to check whether there is a specimen is available for testing. For in case of a lymph node TB, we'll take the lymph node aspirate or a lymph node biopsy specimen. In case of a pleural effusion, we'll take the pleural sample. Or in case of a meningeal TB, we'll take the CSF likewise. So if the appropriate specimen is available, we can go with the CBNAT and check whether this MTB is present, rifampicin resistant is present. And if the appropriate specimen is not available, like example, in case of a spine TB, usually we won't go with a higher risky procedure like biopsy and all. So based on the radiological evidence from MRI spine, if it is 100% sure for the clinician that this is TB spine, he can start him on ATT. So that kind of patient, we call them as clinically diagnosed EPTB patient. Next. So this is an algorithm for TB in children. So any presumptive pediatric TB patient come to us, first we need to do a chest X-ray. Any children if come to us with more than 2 weeks off with the weight loss and all, we do a chest X-ray. If X-ray is normal, we need to evaluate extrapulmonary TB in a case of children and refer them to a higher center or expert for further evaluation, like in lymph node TB, ruling out abdominal TB and all. If X-ray shows some non-specific shadow, first we need to treat them with an appropriate course of antibiotic, and we need to again take a chest X-ray to look whether the symptoms or shadow is resolved or not. If the symptoms is persisting and shadow is persisting, we need to go with, in case of children, they can't expectorate sputum like the adults. So we need to do either expectorated sputum, induced sputum for examination, or we can take gastric aspirate lavage for NTEP approved CBNAT. And if NAT is positive, we can call them as microbiologically confirmed. If NAT is negative, but the X-ray have some finding and the clinician think that this is TB, they can refer them for expert, like I already mentioned, for doing bronchoscopic lavage, or for taking, in case of intrathoracic lymph node, we can take EBUS guided lymph node biopsy from the mediastinum, etc. So like we can diagnose TB in case of children. So these are the various regimens currently available for treating TB. Like previously, there is no category 1, 2, 3. Only one regimen is available for drug-sensitive TB. Whether they are previously treated, whether they are new patient, there is only one regimen. That is 2 months of, that is initial intensive phase of HRCE, we know isoniazid, rifampicin, ethambutol, and pyrazinamide for 2 months, followed by 4 months of HRE. We will omit pyrazinamide and other 3 drugs are continued. So usually the treatment of TB is 6 months. In certain cases, we can extend the duration that I will deal later. Then other regimen is for H-mon or polydrug resistant TB. If only isoniazid is resistant, they are treated with the 6 month of LRZE regimen. L is levoflox. Instead of INH, we'll substitute them with the levoflox, and the treatment is 6 months itself. So currently for MDR or rifampicin resistant or XDR TB, several regimens are available, like shorter oral regimen, shorter injectable regimen, or longer regimen and all. So these are given based on the patient category, how infective they are, how disseminated the infection is, which all drugs they are resistant. Based on this, the drug resistant nodal officer will decide the regimen. So every drug resistant TB should be treated under a public sector from a district TB officer only, not in a private sector. So currently shorter regimen duration is around 9 to 11 months. For XDR TB, the treatment duration is between 18 to 20. Next. So I mentioned like the current regimen, first line ATT is HRZE. Among that, H and R are bactericidal. Pyrazinamide is bactericidal in the acidic medium only. Ethambutol is bacteriostatic drug. So every treatment, the regimen is same. So in case of CNS TB or skeletal TB or disseminated TB, we can extend the treatment beyond 6 months. Or any all other cases, the treatment is just 6 months. So now the TB treatment is given based on the fixed drug combination. So every tablet contains combination of 4 drugs. Like in case of intensive phase, every tablet contains this 4 drug, HRZD in that fixed drug combination, like H75 mg, R150 mg, Z 400 mg, and E275 mg. And the number of tablets decided based on the weight category. So there are total of 5 weight categories, and based on their weight, the number of tablets is decided. So how is this is how the treatment number of tablet is decided. Next. So there are new changes in the NTP compared to the RNTCP is here the daily dosing. Previously we usually give thrice weekly regimen and all. Today TB is treated based on the daily dosing regimen. Previously the dose provider was a ASHA worker or someone health trained worker. Currently dose provider is like family member. And ethambutol is now added to the continuation phase. Previously, it was not there. And currently, the intensive phase is not extended beyond 2 months. The continuation phase can be extended depending on the site of the TB. So currently, there is a change in the definition of MDR, XDR. There is a new term like pre-XDR. So we'll deal that. So who is called as an MDR TB? Any TB patient that doesn't respond to at least INH and rifampicin. So H and R are resistant. They are called as a MDR TB. So who is called a pre-XDR? So any TB patient caused by an MTB strain that fulfill the definition of MDR. That is, they are both resistant to H and R plus also resistant to fluoroquinolone. So HR plus fluoroquinolone. They are called as a pre-XDR TB. XDR TB is TB caused by the MTB strain that fulfill the criteria of MDR TB. That's they are resistant to INH, rifampicin, fluoroquinolone plus additional 1 group A drugs. So what is this group A drug? I'll discuss that. Next slide. Yeah, this is a various group of drugs available for treating drug-resistant TB. There are 3 groups. Just to know that there is a group A, group B, and group C. So we'll include all the 3 medicine from group A, 1 or both medicine from group B, and group C regimen is added when we can't add both group A or group B medicine. That's how we will formulate the drug-resistant TB regimen. So if a patient is resistant to either levoflox or bedaquiline or linezolid, These three are a group A drug. They are called XDR TB. So this is a change in the definition of XDR. Previously, XDR was called as resistant to second-line injectable and fluoroquinolone. Now this changed. This is fluoroquinolone plus any additional group A drugs. So next slide. This is just to show how is the drug-resistant TB diagnostic algorithm goes. So any presumptive TB patient or all notified TB patient. Currently, even if this mutant AFB smear is positive, we need to go them with a CBNAT. That is to rule out rifampicin resistance. So for every positive smear patient, we need to double check them with a CBNAT. Then any patient who is not responding to treatment, we'll go with CBNAT. If in CBNAT, rifampicin resistance is detected, we need to additionally do first line line probe assay and second line probe assay to rule out resistant to the other drugs. If that patient rifampicin resistance is not detected, then also we need to go with a first line LPA. This is to detect H resistance. There is one entity I have mentioned like H mono drug resistant TB. So for detecting that, we need to go with a first line LPA. If H resistant is not detected, we call them as drug sensitive TB and treat them accordingly. If H resistance is detected, further we need to go with other second line injectable line probe assay and rule out other drug resistance also. So next slide. Okay. Now about the index TB guideline, there are certain guidelines for treating extrapulmonary TB. Just to mention that in case of lymph node TB and TB meningitis, guidelines recommend doing the CBNAT or expert MTB for detection because CSF sample and lymph node aspirate has got very high good sensitivity for detection in CBNAT. But in case of a pleural fluid TB, only the pleural effusion TB has got 40% sensitivity by detection via CBNAT. So we should not use CBNAT alone for confirming a pleural effusion TB. We use other method like ADA. ADA value, if more than 40, is more sensitive of TB. Then we'll go with a thoracoscopic biopsy from the pleura, etc., to diagnose the pleural fluid TB. Now, which are the cases we use steroids in case of a TB patient? Only in TB meningitis and in some cases of TB pericarditis, we currently recommend steroids. In all other cases, steroids is not recommended, especially in pleural TB. Previously, there was a recommendation for giving steroid. Now it is not recommended. So duration, I have mentioned for every TB, 6 months ATT is given. Example, lymph node, abdominal TB, ocular, cutaneous, etc. TB meningitis, the treatment duration is extended up to 9 months. Whereas TB spine, it can be extended up to 12 months. And TB of any appendicular skeleton, we can extend it up to 10 to 16 months, depending on the site of TB. So, something about the treatment outcome. When a patient is called cured of TB, any microbiologically confirmed TB patient at the beginning of treatment and at the end, we'll again recheck them with a smear. Then at the end of the treatment, if the smear is negative, we'll call them as cured of TB. And who will call as a failure? Any TB patient who's positive at the beginning, at the end, if they're still positive, they are called as failure. Who is called as failure to respond? This term is usually dealt with the pediatric TB cases. If they fail to have a microbiological conversion to negative status at the end of 12 weeks, they are called as failure to respond. Lost follow-up means any TB patient who was interrupted for 1 month or more, they are called as lost follow-up. Not evaluated, the patient's outcome is not evaluated. Such patients called as not evaluated. Treatment regimen changed means any TB patient who is on a first-line regimen and diagnosed to have a drug-resistant TB later and switched to that regimen, they are called treatment regimen changed. Died means any patient who died during the course of ATT. So these are the several outcomes of a TB treatment. Briefly regard of the adverse drug reaction of TB medicines. First, INH. INH not to cause peripheral neuropathy. We usually give pyridoxine along with ATT to prevent peripheral neuropathy in case of INH toxicity. Then skin rashes is usually seen. Hepatitis, DILI, drug-induced liver injury is more commonly seen with INH. Some patients may also report sleepiness and lethargy. It's known to cause GI intolerance, hepatitis.
Zoom meeting
Can non-presenters please mute?
Okay. So rifampicin can present with generalized cutaneous reactions and thrombocytopenic purpura. Pyrazinamide, we'll usually see some patients with TB patients known to have hyperuricemia. This is due to the pyrazinamide-induced arthralgia. So if once we'll stop the medicine, the hyperuricemia get better. Then ethambutol. Ethambutol is notorious to cause retrobulbar neuritis. It's very important that every TB patient on the follow-up, we need to ask whether they have any vision dullness or color vision problems and all, because many patients may develop retrobulbar neuritis after 3 months of starting ATT. So this is one of the important side effect. Many times patient may report blindness if we are not go with a thorough monitoring. If they doesn't have a correct monitoring, they will present with blindness at the end of 3rd or 4th month. So it's very important. Then streptomycin, we'll know they cause allergic reactions, vertigo, nausea, vomiting, hearing impairment at all. Next. So if any adverse drug reaction is reported, the patient's dose of the drug should be checked. Other causes should be ruled out. Seriousness should be estimated, and area should be registered in the NICSHI portal. Then the drug need to be stopped, and we need to reintroduce gradually, one by one, when the symptoms disappears. And we need to ensure the drug resistance is not developed meanwhile. So lastly, a few words on latent TB. So what is latent TB? Any latent patients who have a presence of Mycobacterium tuberculosis bacteria in their body, but doesn't have any signs, symptoms, or radiographic evidence of TB. Such patients are called as latent TB infection. So WHO have recently given guidance for giving TB preventive therapy for 3 groups of people only. First is household contact of people diagnosed with microbiologically confirmed TB, people living with HIV, and certain risk population like people on anti-TNF therapy, CKD patients receiving dialysis, and organ transplant receive also. And especially patients with silicosis. Silicosis patient is more prone to develop TB. So in this kind of patient, WHO give guidance for giving TB preventive therapy. It is said that giving TB preventive therapy will decrease the risk of developing TB by 90%. That is from 11% for not taking infection treatment to 1.2% for those who taken the same. So it's important that effective implementation of TB preventive therapy alone can result in a decline in annual TB incidence by 12%. So this latent TB test, we know usually we go with Manto test or tuberculin sensitive test. Now we usually don't do this test. We go with IGRA testing. IGRA is done in a blood. And third one is CTB test. This is also a skin test recently developed for detecting latent TB infection. So there are 3 regimens available for treating latent TB. First is 6 months of daily, 6 or 9 months of daily isoniazid. Second is 3 months of weekly rifampicin plus isoniazid. That is called as 3HP. Lastly, 3 months of daily rifampicin plus isoniazid, 3HR. So 3HR is usually given, especially for children's or household contact. If they are positive for IGRA, we give 3 months of H&R as TB preventive therapy. So thank you for patient listening. If you have any query, please feel free to ask. Thank you. So there are certain
questions seen in the chart.
Many patients with INH monoresistance may get missed out in the initial assessment, may get missed out because of our algorithm only looks for rifampicin resistance. Yeah, that's why currently the regimen says that even if the patient is drug-sensitive TB, even if rifampicin resistance is not detected, we can go with first-line LPA. First-line LPA, we can know whether the patient is resistant to H or not. So by doing that, we can rule out the H monoresistant TB. So prophylaxis, I have mentioned there is only 3 regimens currently available. Usually we'll go with 6 months of INH or 3 months of H plus R or 3 months of H plus rifampicin. Rifampicin is called as P, 3HP. That is a weekly regimen recently developed by the government. So these are the 3 prophylactic regimens currently available, but it is not given for everyone. If INBR, we test the latent TB, will be definitely positive for IGRA or MANTO. But government give only TB preventive therapy for 3 risk groups. One is having household contact, other is people living with HIV, and next is, I have mentioned certain risk category peoples. For them only TB prophylactic therapy is currently given. TB, one question, can you explain TB not evaluated group? TB not evaluated, just that at the end of 6 months, if we don't check whether sputum AFD is positive or negative, we have not evaluated the patient at the end of CP. They are called as a treatment TB not evaluated. That's it. We are not sure whether the patient is cured or free of the treatment.
There's one question on drug modifications in ATT-induced hepatitis.
Yeah, drug modification. So in case of a delay, first we need to stop ATT. The delay is called when SGOT or SGPT is more than 3 to 5 times the upper limit of normal. Just borderline elevation is not taken into account. If it is more than 5 times the upper limit of normal, we will stop the ATT medication. Wait till the LFT comes to normal. Then first we'll re-challenge one by one drug. First we'll start with INH, half the dose, then give the full dose. Likewise, we'll step up the dose one by one drug. If the patient develops DE at any point of time, we'll omit that drug and continue with the other 3 drugs. So in such cases, we can add other drugs like streptomycin and levoflox. These are the 2 drugs which are given for the interim period. While switching on the regimen, we'll start them with SHE regimen, that is streptomycin, INH, and ethambutol regimen. We can omit rifampicin and pyrazinamide if the patient is having DE, and we'll go with this regimen. If the patient is not tolerating that too, we can omit H and start them on SLE regimen, that is streptomycin, levoflox, ethambutol. So here, streptomycin is given for the first 2 months, and levoflox and ethambutol can be continued up to 18 months. So in case of a treatment regimen change, we need to extend the treatment duration, and injectable need to be added. So that's one thing regarding delay. So the various guidelines are available for that too, for management of adverse drug reaction of TBs.
Another question is pyridoxine advised and is 10 mg available?
Pyridoxine, in case of a normal patient who doesn't have any symptoms, we can start them with pyridoxine 10 mg. If the patient is having symptoms like numbness of feet and all, we can step up to 25, up to 100 mg per day, we can step up the dose of pyridoxine. Pyridoxine is usually given in government setup along with an ATT. We will usually give around 10 mg pyridoxine.
So why are we not giving TPT to all household contacts?
Yeah, for household contact, if we have a child less than 5 years, we won't go with a IGRA or MANTO test. We'll straight away start them on TB preventive therapy. For children less than 5 years. For adults, we'll go with IGRA or MANTO. Even if it is positive only, we'll give them with the TB preventive therapy. If negative, we won't go with the treatment. Only for children less than 5 years, we'll treat them with a TB preventive therapy. Even if it is the IGRA's, MANTO's not done.
A question about sensitivity and specificity of IGRA and SIGINAT.
Sensitivity. CBNAT, the sensitivity is around 95% and specificity is 98. IGRA sensitivity of detection of latent TB infection is more than 90%.
So the question is, what tests do we do for ruling out TB before starting high dose corticosteroids for other indications?
Yeah, if we start corticosteroid for short duration, there is no indication for doing this latent TB diagnosis test. If we are planning for any immunosuppressive therapy for long duration or long high dose steroids for long, or if a patient is preparing for organ transplant, for that kind of patients, we can do this latent TB test like IGRA. If it is positive, we can treat them with TB preventive therapy. And if it's positive, we need to rule out active TB by doing sputum smear examination, X-ray and all. Only after ruling out active TB, we will start them with the preventive therapy.
So question is, in case of MDR TB of a patient, then what regime should be given to household?
I didn't get it. What's it?
In case of MDR TB patient, what regime should we give to household?
Household. If a patient is MDR TB, we'll go with the IGRA test. If IGRA test is positive, we'll look whether the patient is resistant to rifampicin or INH. If a patient is rifampicin resistant, we'll shuffle them with levoflox. But that regimen is not currently given throughout the India. So this program is gradually building up. We'll give only TB preventive therapy for drug-sensitive TB currently, not for this drugs-resistant TB. But the guidelines say we can shift them with levoflox.
When should we do IGRA test?
What? I didn't get.
When should we do IGRA test is the question.
IGRA test is done only if a patient come to us and tell we in the house we have a microbiologically confirmed TB patient, we have got exposure to that, when we will do with IGRA, or any patients with HIV. Before starting their ART, we'll do the IGRA test, or any patients with doing CKD on doing dialysis before starting, or long-term immunosuppressive therapy, patient with silicosis, because silicose patients are more prone to develop TB, and organ transplant recipients. These kind of patients only will go with IGRA. Other patients, if some children come with more than 2-week cough, we don't go with the IGRA. We'll rule out active TB only. We don't usually do the IGRA matters.
For confirming TB, I think we have already answered the question. For confirming TB, CBNAT versus AFP smear.
So both is used for confirming TB. First, AFB smear. If positive, it is microbiologically confirmed. If it's negative, go with CBNAT, because CBNAT has got better sensitivity when compared to the smear examination. Both are used for confirming TB.
And is contact restricted to household, or any outside contacts should also undergo IGRA is the question?
No, only household contact, because we are all contacts of TB patient. I usually see 1 to 2 patients of TB every day. So I can't go and do an IGRA. So only household TB patients are not to do IGRA.
So I just have a question from my side. So if some of our staff, nurses or someone is turning out positive for TB, so others are apprehensive. So do you recommend to do IGRA, or what kind of test should we advise them?
If we have a contact with the TB patient in our work settings, we'll look whether we have any symptoms of active TB. If we have persisting cough, fever and all, we'll look like we do the smear examination, X-ray. IGRA is not recommended in that kind of settings, because if we come as positive, we'll get a dilemma. The government won't give drug for a healthcare worker contact. Government won't give drugs. So in such kind of patients, we only rule out active TB, not the latent TB. Every clinicians, especially the pulmonary or primary care physicians, must have come in contact with the TB patients in once in a while in their clinical practice. So usually they will be positive for IGRA or MANTO if you do that.
So the question is, what are the samples that we can use for CBNAT, and for which sample the sensitivity is high?
CBNAT, the highest sensitivity is for sputum, of course. Then for the extrapulmonary sample, highest sensitivity is for the lymph node aspirate. Then CSF sample also have high sensitivity. Pleural and ascitic fluid has got only 40% sensitivity, less sensitive. Others have got good sensitivity.
So one administrative kind of question: in private sector, is treatment allowed only for drug sensitive TB, or drug resistant TB treatment is also available?
No, only in private sector we'll treat the drug sensitive TB. If a patient come to us as resistant to rifampicin, we need to refer them to the district TB center or district TB offices. They will formulate the regimen based on their patient specificity. So, and the monitoring is done only in the public sector, not in a private hospital.
Next question, I think you have already answered, is the treatment options for latent TB, the 3 regimes you have already mentioned.
Drug-induced hepatitis, yeah, the monitoring of TB. Every TB patient before starting ATT, we need to do LFT, RFT, baseline ophthalmology evaluation. And every fortnightly, that is every 2 weekly in case of IP. First 2 months, we need to regularly do LFT and RFT every 2 weekly. After 2 months, every monthly, we need to recheck the LFT and RFT.
I think we are done with the questions. I think it was a wonderful session. We had around 90 plus audience attending, and still now we have 60 plus. Oh, thank you, Dr. Aishwarya, and I hand over to Dr. Aishwarya Nambudri, who is the state lead for Spice Route Kerala, to deliver the vote of thanks.
Thank you.
Thank you, Dr. Vishnu. It was indeed a wonderful session, a very informative one, and I think everyone wanted to hear this topic. So I take this opportunity Thambi for taking her time and delivering this wonderful presentation. Thank you, Dr. Aishwarya. And I would also like to thank all the participants who were there from beginning to end. I think there were around 100 participants. So thank you all.
I think we can wind up the session, right?
Okay, thank you for inviting me, and it was a pleasure meeting you all. Thank you.